Hello viewer, welcome to today's episode of our talk show. We are continuing with the discussion where we left last week about cancer. I'm your host Lucy Wansakariuki. We still have the same guest whom I would like to invite so that he introduces himself. Welcome to the show and kindly introduce yourself.
Thank you so much, Lucy. Thank you so much, GBS, for having me. And we continue on the talk about cancer. My name's Ben Bello Onyino. I'm an oncology. I work in Kenyatta National Hospital.
Thank you so much from the highest hospital in the country, whereby we have received even international patients and clients. Welcome. We are so honored to have you today. We were talking about cancer last time, and today we are continuing with cancer. You told us that cancer has been a burden in so many ways in our country. And the first burden, which maybe we didn't mention last time or we did in a lesser note, which I would like you to start with as you remind our viewer what cancer is awareness. Little or minimal awareness. Are people aware that cancer is there? Welcome to the show.
Thank you so much, Lucy. That's also a very good question. About the awareness about cancer, people, quite a percentage is aware.
Yeah.
And you find there is a percentage that's not aware. So there is that mix. But quite a good percentage right now that have been informed.
Yeah.
And you find, for example, when we have the screening, when you have maybe a cancer month in the country, when you have a screening, quite a huge number of people normally turn up to be done screening.
Yes.
Both genders, but mostly find women who will come out to be screened for the cervical or breast cancer. So as per right now, we are not like those years where that awareness was very low.
Yeah.
Quite there's that desire to know more. Simply because I believe, because you find somebody either has a relative who had cancer or a friend, they're aware about a friend who has or had cancer. So that's what has made most people to come out in large number to go for this screening and to have that desire to know more. So the awareness is there, but not to that level you can say it's satisfactory.
We can say we are somewhere.
Yeah, we are somewhere.
But we haven't reached our destination.
Not yet.
That everybody, everywhere, cancer is known.
Yeah.
What about the screening equipments, the tools that are used to screen this cancer? Suppose now we go to a rural area like vast dry lands and far lands of Ukambani. Let's go to Kitui, the interior where it borders Somalia. Can we be able to screen cancer from that level? Or is it just in the towns?
That's a good question, Lucy. There are some cancer which you can screen even right down in the village. For example, for cervical cancer, pap smear. Pap smear can be done even in a health center.
Yes.
You can do a pap smear just to examine and see the changes. Then also a mammogram. A mammogram can also be done right down at the board of Moyale. As long as that health facility has an X-ray department or a radiology department, they can also have a mammogram.
Yeah.
So screening can be done right down in the village, depending with which type of cancer being screened for.
Yeah.
Yeah. But there are some which you have to travel to, like in Nairobi here, or these big cities in the country for screening. Yeah.
But generally, cancer can be screened across the country.
Generally can.
Generally.
Yes.
Yeah, and at least something can be done.
Yes.
Whether it is physical exam like the breast cancer, whereby most of the time you don't need to, before, in the initial stages, you can just examine the patient, which means it can be screened.
Yeah, like for example, if I may draw back to breast cancer, it's good to sensitize the healthcare workers across the country. For example, so that they are able to teach all girls on breast self-examination,
Yes.
on the importance of breast self-examination. Then after a certain duration of time, they go for clinical breast examination.
Yeah.
Then after a certain duration of time, they can do an ultrasound. So once these things are followed or adhered to or routinely followed by healthcare workers and also that lady in Moyale down in the village or Turkana, you are able to detect this cancer at a very early stage in case they'll develop cancer at one point in their lives.
Yeah.
Yeah.
Thank you so much, Ben, for that. You're just opening my mind, and maybe next time we will be demonstrating the breast cancer examination, because it is good to know, even for men,
Yeah,
because
true.
these are our husbands, our brothers, they are our children, and they also need to know that this is not a woman thing. Because I sometimes you see wanaume watoke, we speak to women, and sometimes I wonder, why are we discriminating, or don't you think so? But a man needs to understand.
Sure.
Yes.
You see, from my point of view, it's very important to engage both genders in all this health information. Because at the end, just as you said, it's either a spouse or a child or a daughter. In one point, they are related. So if we involve all of them, they're able to take part in the screening and in case of diagnosis, also in the treatment, because it's a journey. They have been working right now from the screening and also encouraging each other that these you are supposed to be doing maybe a pap smear every year. So if you have not involved the spouse, you find this lady maybe will be hiding to go for that screening, and this man will be wondering what is being done to my wife. But if this man has been involved from word go, I can also encourage my wife. Well, but there, it's your time for you to go and do a pap smear.
Yes.
Or if the wife has been involved, she is able to tell the husband, this end of the month, you can examine your prostate gland. We can even do it together.
Yes.
Because it's involving both sides.
Yeah.
And by so doing, we are trying to detect this thing at a very early stage. So by involving both parties is also very important in this
Partner involvement. Yeah, thank you so much for that. At least I've learned something. Chemotherapy. Today, you can talk to us about chemotherapy. What is this we call chemotherapy? It's a very, very huge name. When you who is working in a cancer center, you may not know. But ask us who are outside in the community. Chemotherapy is a very big thing, big word. Kindly make it simpler for us. Bring it home, because we fear when we hear she's on chemotherapy. Many people think it's a death sentence.
Thank you, Lucy, for that nice question.
Yeah.
Okay, chemotherapy, if I may start from top going down slowly.
Yeah.
Chemotherapy, these are drugs which we use to treat or either to cure, to control, or to palliate cancer patients. In curing, I'm aiming at almost 90% rate of curing this disease. In controlling, it's just slowing down the rate of this disease progression. In palliative, just to relieve maybe there's some pressure. So chemotherapy, these are drugs which are administered either intravenously in a health facility, accredited health facility to administer this chemotherapy. Remember, you're not just supposed to do it at any center. So when these drugs are administered, the main aim of these drugs is to destroy the rapidly multiplying cells in the body. If I may say, cancer, these are just the normal body cells which become abnormal and begin to multiply very rapid.
Yes.
So this chemotherapy, they normally target these cells, this type of cells. They go, they attack them, they destroy them, or they kill them. That's how it works, chemotherapy. And you find in chemotherapy, that's why I've said it has to be administered in an accredited health facility by the government. Then, at least patient has to be informed about the mode of treatment.
Yeah.
How do they work? Then the side effects of these drugs. Then the frequency or the cycles. How many cycles am I supposed to receive? Because each treatment or each cancer has got its own cycles of chemotherapy one is supposed to receive. Then the frequency. There are some drugs which the patient is supposed to come after every 2 weeks. And there are some patients supposed to come after every 3 weeks or 4 weeks. Basically, the reason is normally just to give the body a chance to, because they normally attack the fast growing cells. In the process, also the normal cells are also attacked. So just giving the body the chance to rebuild itself. So besides the chemotherapy, the patient also, after being taken through the mode of action, how these drugs will work, the side effects, the patient has to give a consent. He has to sign. Sign down, they have been explained, this is how this is the cost. It's also very important to tell the patient the cost. Because you might start a patient on a certain cost, the drug or chemotherapy, and the cost is very high. I told you the cost of this treatment is very high. For example, there are some drugs which can go for like 450,000 in a month. So you can imagine this patient repeating after every 2 weeks, 225,000 and in a month. So you just initiate this patient on this treatment. Now, we have not explained about the cost, everything. They'll start, then the next cycle, they're not able to continue.
Yeah.
So it's very important to explain all these things. So on the chemotherapy, the side effects that we have things like hair loss, because in our body, some of the fast-growing cells, it's our hair. It grows very fast. So they fall also victim to this. That's why you find most patients on chemotherapy, they lose their hair. But this is not permanent. It's normally reversible. After they complete the treatment, it's normally reversed. The hair will grow back after like 3 to 6 months. There'll be another regrowth of hair. Then some of the side effects that we normally experience is like nausea and vomiting. But all this, the nausea and vomiting, how we manage them, there's some drugs we administer to stop the nausea, to stop the vomiting, or to control the nausea. Or also we advise on the nutrition, on how to eat, or what not to eat during this treatment, so that it doesn't make that vomiting worse. So there are so many, it's a journey when starting the chemotherapy. It's a long journey that healthcare worker or the oncologist has to take this patient through. Not only the patient, even the caregivers, because it's a multi-team. When it comes to cancer, we talk about a whole team managing this one patient. Yeah.
You've talked of consent. We have so many treatment in the hospital apart from surgery. And patients don't give a consent. You come with we are giving you antibiotics, you just given. Why are we consenting in cancer treatment?
That's a good question, Lucy. We are consenting because of the side effects that these patients are likely to experience while undergoing this treatment.
Yes.
So I've talked about hair loss. You can imagine this patient, a lady, hair with the ladies. Then all of a sudden I'm losing my hair. This patient will be worried, or even possibility, some even having a chance of even taking it further, even suing this institution. So you have to take them through this journey, explain to them all these things so that they may consent to this treatment, and they will also adhere to it till the end, because it's a long journey. It's a chronic illness. So they have to consent that they have to go through this treatment till the end. So the reason they normally consent to this treatment is the side effects, the adverse side effects that you expect these drugs might have on our patients. But most of them, they are manageable, but it's good at least to consent onto this treatment after thorough explanation. Yeah.
Are there clients after explaining about the cost, about the side effects, just refuse to get the medication and go home?
Wow, that's a good question, Lucy. Yeah, there are so many clients who have refused, because I've told you there are some who still believe this is a curse, this is a myth. Some who believe that I'll go for prayers and it will be healed or will be cured. So there are some who will refuse, either because of what they have heard from other people about the treatment. So they'll just refuse, or what they have seen. Maybe they have had a relative, or they have had a friend, or they have seen somebody, whatever they have undergone. So they'll refuse the treatment. And there are some who will start the treatment, then in the middle, due to the side effects, they'll just refuse the treatment. They'll say, imetosha yostaki, because these side effects, we have even had some scenario whereby a patient, when maybe they meet you in the streets after you have administered the chemotherapy, for example, I can give one side effect of nausea and vomiting. They'll just vomit because they associate you with that treatment. So they'll just vomit.
Wait a minute. You are the healthcare worker. You administered the drug. Now you meet the patient on the streets and they start vomiting.
Yes.
Oh my God.
Yeah, it happens. In vomiting, when you talk about vomiting, chemotherapy-induced nausea and vomiting, there are 5 types of vomiting.
Yes.
One of it is whereby this scenario whereby a patient, either when this patient comes to your facility or healthcare facility where the chemo is administered, immediately they start to vomit. Or if they encounter the healthcare worker who administers that chemotherapy, they just start vomiting. So it's a wide topic. Yes. So we have patients just in the middle of treatment, they decide to stop the treatment or discontinue it.
Do you trace or you just leave them? Suppose you had given a client drugs for 1 week or 2, and it was supposed to run, for example, 6 weeks. And after 3 weeks, you are not able to see the client. Do you go looking for the clients? Like, where are you? Is it financial problem? Is it this and this? Do you do contact tracing?
Yeah, we do the contact tracing. We have the social workers who normally make a follow-up on these patients. If a patient maybe has been out there for long without coming, because one, with our patients, it's a team. We'll take the contact of the next of kin. So you'll find either they'll come to the facility and tell us, maybe my patient or my mom or my son or my father or has not been feeling well, so he's not able to continue the treatment.
Yeah.
Or maybe they'll tell you maybe they have succumbed, or sometimes they'll just tell you maybe this patient has refused treatment, so they'll come to seek advice on how you can pick it from there, or maybe advise them or do counseling, or maybe you can go and pick the patient at home. We have a scenario whereby the patient, they refuse treatment, and the caregiver will come to the facility to seek assistance on how we can help them. Maybe start the treatment again. And also we have a scenario whereby the social worker will have to step in. If you notice that this patient has not been coming for a very long time, and maybe you have not referred them to a closer facility to their home, it becomes a concern. You make a trace contact to find out what's going on with this patient. Yeah.
Wow, that is so nice. At least we've known that you people experience a lot.
Yeah.
You also suffer the blame for the good work that you're doing. Because I'm just imagining a patient vomiting because he has seen you. I would like to know if I will run away, hand over the patient to another person, but this is so nice. At least vomiting has been mentioned too much in relation to cancer treatment, and also the air loss, which many people have seen, many people who have undergone it, and the beautiful hair is gone, and even when it grows, the beauty that was there in the beginning, you know, is not there.
Sure.
And now I understand why you have to give a consent. Viewer, this is TBS TV Africa. We are going to continue after the break. The discussion continues. It's on cancer, chemotherapy, which is a modality used to treat cancer. And we were just completing the show, whereby we were talking about nutrition. Daktari has said it must be a balanced diet, and we know that when it comes to managing the patient, as much as we are giving the medication, as much as the patient is eating, we also take care of the mind. Now we will just talk about psychotherapy for the patient. We have all these signs and symptoms, Daktari, you have talked about. You've told us that you have to give a consent, permission for you to be given these drugs because of the side effects. How do you manage the mental health status of the patient? Because this is not something easy, that I'm going to undergo a process which is going to leave me in a state that I don't know how I will be able to come out of it. How do you take care of the mind of the patient?
Thank you so much, Lucy, for that nice question.
Yes.
Let me draw you back a little bit about nutrition still. Maybe I can also add.
Yeah.
On the side of nutrition, we talked about nausea and vomiting being also one of the side effects.
Yes.
So I can imagine somebody having nausea and vomiting, then you're telling them to eat, to come for
Paradox.
the next cycles, because I expect this patient to be fit when they come for the next cycle.
Yeah.
Yet they have nausea
And
due to
vomiting
as a result of the drug that I've administered. So I say, do you normally administer antiemetics or drugs which normally stop or control vomiting?
Or relieve.
Yes. Then on the side of nutrition, we'd also normally advise them to be taking small and frequent meals.
Small and frequent.
Yes, small and frequent. Because right now this patient, he cannot take the same quantity of food they used to take when they were fit. Because right now they are sick, then also adding treatment to it has become worse. So we normally advise them to be taking small but frequent, because at the end of the day, when they're taking small, frequent meals, it will sum up to be whatever they are almost eating when they are fit. On talking of the psychotherapy, this is a vast topic again on talking about cancer, because having in mind the diagnosis, we're not talking about an ailment like malaria.
Yeah.
We're talking about a chronic illness, which has stigma to it.
Yes.
Because most people know it's cancer, death sentence. They begin even to count the days. But when it comes to psychotherapy, in oncology, you don't manage it alone. It's a multidisciplinary.
Yes.
You have to involve so many people. You have to involve the palliative team. You have to involve the mental health care team. You have also to involve the spiritual part of it. You have to involve the pastor or the sheikh or the priests. You have to bring all these people on board to manage this patient. When you start with the psychologist also, for counseling, you have to take them through the palliative team. They counsel this patient on the long-term treatment this patient are going to go through. Whether it's radiotherapy, chemotherapy, they have to take them through the counseling, the preparation. This is what you're going to expect. This treatment is so short-term. This treatment is going to take like 4 years. There's also a chance of recurrence. In case it recurs again, you have to undergo this treatment again. So there's need for that preparation of psychological part of it. So you have to involve the palliative team. They talk to this patient in length. And it's not just a one-day thing. Counseling can even take even a whole month.
Yeah.
It's a continuous thing. Then when it comes to the spiritual part, you need to find out their belief. The spiritual belief. What do they believe in? If the person, yes, culture also. Yeah. You have also to talk to about if there are Muslims, the imam. You have to bring them on board so that they handle the spiritual part and be handling it. If there is a Catholic, same. You have to bring the priests to handle it, to talk the spiritual part of it, because you need to find out from the patient what do they believe in, and tackle from that angle.
Yeah.
There's the psychological, the psychotherapy part still involve the financial part of it. For example, maybe they are not financially stable. You need to bring in the social worker and see how the social can step in. Because if somebody financially is not stable, definitely the treatment will not go well. Because I'm trying to imagine the cost of treatment is go for 50,000 per month.
Yeah.
I begin to think, how am I going to get this money?
Yes.
Right now, I'm not working. I'm not in business. So you need to bring in the social worker. Social worker maybe will try to liaise with other organizations, which normally also support these cancer patients. So it's a wide
Yes.
part of it. The mental, if this person is disturbed mentally, you need also to bring the psychiatrist to assess. So this is a wide topic, the psychotherapy. It's a multidisciplinary, you have to involve a wide range of people to come on board and assist this patient. Not only the patient, even the caregivers. And not only the caregivers, even the healthcare workers managing this patient. Because if this healthcare worker is not also psychologically fit or mentally fit because of whatever they are seeing this patient going through, somehow is at one point you might find some error also happening. So you also need to take care of the psychotherapy part of the healthcare worker. So it's a wide topic.
Yes.
Yeah.
Okay, wow. So the patient has to come into terms with so many things.
Yes.
And one of the most important thing is that the patient has to know that the center of it all is the treatment.
Yeah.
After doing all that, we said some will decline. And some, but most of them are going to accept. Now, when it comes to stigma, because of the death sentence that comes with it, are there clients who just say, I don't believe that I have cancer?
Yeah, that's a good question. Yes.
These are the results.
Yes.
The names are there. But maybe because of the denial, they say, I don't believe that I have cancer.
Yes, I've seen several, one or two. I've seen when some, they have started treatment, then not even the client. You see, it's almost a family issue. So you find also the family coming and saying, we know somebody somewhere who normally handles these things in a local way. So they pick the patient from the hospital and they take them to the village to be managed by those herbalists. Only for them to come back later on and tell you, hey, but we have been again, or you have been defeated, or the herbalists have been defeated.
It is not working.
Yes. So it happens, you find somebody, there's that denial, just like in any other condition, there's something called denial. Somebody telling you, I don't have cancer. It's almost normal for somebody to deny it because maybe they believe they're not in that category of people who are not supposed to be sick from this illness. So there's that denial, but you have to take them through the counseling process slowly and come to that acceptance that already it's here with them. So how do we pick from there?
Yeah.
So, and also you have some who have been diagnosed with it. They start the treatment, then in the middle, they abort the treatment because they believe maybe they have been cured or they have been misdiagnosed.
Yeah.
And so it's something common to find amongst some of our patients, of which is some are very rare, but you still find one or two cases of such magnitude.
Thank you so much, Ben Bella. This was so wonderful having you in this show. We've come to the end of our show. Kindly face your camera, say your parting shot, remind your clients where they can find you.
Thank you so much, Lucy. Thank you so much, GBS, for having me and to talk to our viewers about this issue of chemotherapy and cancer treatment. It's my pleasure of having me here, talk to your viewers on this big and enormous topic about cancer, which it'll be my pleasure to come and demystify more information about the treatment of cancer, the cancer itself, the screening, so that the public might be enlightened, or the GBS viewers might be enlightened about this thing of cancer, the treatment, the screenings, and everything that's available. My name is Ben Bella Onyino. I'm found in Kenyatta National Hospital, Oncology Department.
Thank you so much. Viewer, this is GBS TV Africa. We were dealing with chemotherapy, and for sure, this is just drugs, simple medication. Until next time, bye-bye. I was your host, Lucy Wanza Kariuki.